Discuss different medications that you can use per ADTMC, but also some medications that you should be familiar with so that you know that you can't mix ADTMC medications with them, and then how to properly document giving those medications, and some other preventative measures that you can use for soldiers that we're giving these medications to. Medication that we're going to talk about is Tylenol. Someone back in the day who wanted to watch the world burn decided that every medication has to have two names, and so it's also known as acetaminophen. Generic name is Tylenol, brand name is acetaminophen. It's important for you to know both names of medications because not knowing those things is one of the ways that soldiers could lose confidence in you very, very quickly if they know something like that and you don't. So very important to know both medications, be familiar with that. Really, the goal of this PowerPoint is not to have you memorize a bunch of medication doses. This is one that you should be familiar with, that 4,000 milligrams is the max, but you can always look these things up in ADTMC, and we'll see that on the next page when I show you the actual screenshot of the page on ADTMC. But the goal here is really not to memorize these doses. You can always reference ADTMC. The goal is really to just be familiar with the medications. Tylenol is used for a lot of things, mostly like fevers, any like MSK pain, headaches, cramps. It works very well for those things, and it's nice because it can be taken with NSAIDs, and we're going to get into NSAIDs a little bit here soon. But knowing that Tylenol is not an NSAID, so you can take them with NSAIDs for breakthrough pain is very important. Directly from ADTMC. If you get on ADTMC, I would highly recommend kind of like pausing this video right now and actually opening ADTMC and scrolling to page about 180, and then it lists every medication that you're able to give per ADTMC and gives you all the dosages and gives you all this information. So that's very helpful. You can always look back and reference this. Next we're going to talk about is ibuprofen. This is also sometimes known as Rager candy if you hear one of your soldiers say that. It has many other names, but the most common ones are Motrin and Advil. Common doses would be, at the most, I'm giving someone 800 milligrams every 8 hours. That's the most I'm giving someone because the max is 3,200 milligrams in 24 hours. This is best for like acute pain because it can be very difficult on their stomach. So if somebody is taking ibuprofen 3 times a day, 800 milligrams every single day, that's usually better for them to transition to something else other than ibuprofen. But let's say they twist their ankle and it's kind of swollen, kind of painful. This is good to take for a week or two to get that swelling down. NSAID is naproxen. This is also usually known as levonaproxen. The dosage range that I'm typically giving someone for this is 500 milligrams once in the morning and once at night. Technically the max is 1250, but I'm really not giving anybody more than 500 twice a day. You'll notice that in all of the slides for the NSAIDs, they have similar side effects precautions. They can cause some stomach upset. So worst case scenario would be if someone takes way too much, they can give themselves gastritis or a gastric ulcer. Those are the things that we want to avoid by taking those people who are taking naproxen or ibuprofen every day and maybe transitioning them to something else. You definitely don't want to mix these medications because then you put those soldiers at a higher risk of those things. And so you don't want to give someone naproxen if they're already taking ibuprofen or if they're prescribed meloxicam or Celebrex, and especially if they've had a Toradol injection in the past 24 hours. And we'll get a little bit more into Toradol injections later. ASA, but that's not super common. But you have to know that it's present in Excedrin as well. So the Excedrin migraine medications, it is present in that. Really the only time that I would recommend medics using aspirin is if someone's having acute chest pain, because you can give them 4 baby aspirins to chew up immediately. And that's really the only time that our soldiers should be taking aspirin. Young, healthy people should otherwise not be taking aspirin on a regular basis. That's when we should switch them to one of our other NSAIDs, such as ibuprofen or naproxen or Celebrex, meloxicam, one of those. Toradol. A lot of you should be familiar with the infamous Toradol injection. It's great for that acute back pain, someone who has chronic back pain and then they just throw their back out and they're really locked up. Toradol tends to help really, really well with that. The max is 60 milligrams, but I'm almost never giving someone 60 milligrams of Toradol. I'll typically give them 15. And from what I've seen and from what research shows, that has the same effect as 30 or 60 milligrams. And so getting someone an injection of 15 milligrams of Toradol can take them from that acute back pain where they can barely move to at least being functional. It is very, very important before you give someone a Toradol injection that you verify that they have not taken any other NSAIDs in the past 24 hours. If they have taken NSAIDs in the past 24 hours, we can't do a Toradol shot, and they probably need to see me in the clinic if they're very locked up, because then they might need to be put on a muscle relaxer. But I've seen this medication work even better for that acute back pain than muscle relaxers in my experience. Other NSAIDs, the important reason for you to be familiar with these medications is that if someone's on this prescribed daily, we can't give them any of those medications that I just talked about except for the Tylenol. And so meloxicam, also known as Mobic, indomethacin, also known as Indocin, that one's typically used for gout if someone has a history of gout, and then Celebrex or Celecoxib, and then diclofenac or Voltaren. But a lot of times the diclofenac or the Voltaren is prescribed as a topical gel. And so if they're taking a topical gel, you can also mix that with other NSAIDs, but you have to clarify that they're using it as a topical gel and they're not taking it as a pill. If they're taking it as a pill, we don't want to give them any of these other pills except for Tylenol. Now we can touch on some steroids. When we talk about these topical steroids, I touch on this a lot in the derm lecture. If you have seen that one, if not, recommend watching that one. I'll touch on this a lot more. But if you suspect that something is fungal or bacterial, you don't want to use a topical steroid. And so that's super important. It's always safer to treat those things and be wrong than to give someone a steroid if they may have those things, because you could make a fungal infection or a bacterial infection worse. But let's say someone has a history of eczema, they know they have eczema and they're having a flare-up, that's when you can use these kinds of medications. And so hydrocortisone is very, very safe, pretty harmless. You can use it for eczema, you can use it for psoriasis, you can use it for like contact dermatitis, so somebody touches poison ivy and now they have a rash. If they have it on the face or genitals, that person needs to see a provider. You at least need to reach out to a provider and ask some questions, because there might be some further plan that we need to do. Triamcinolone, or also known as Triderm, is just another topical steroid. I've seen where hydrocortisone didn't really work, but this one did because it's a little bit more potent. All of the same things that you would use hydrocortisone for, and all of the same precautions. So if you think that it's bacterial, you think it's fungal, then you don't really want to use a topical steroid. Other steroids that can be used, this is just for familiarization for you to know these medications. You can't give these per ADTMC, and so I would be the one prescribing this even if we're in a field setting. Prednisone and methylprednisolone, they can be used for various different issues, but in the field I've seen them used pretty commonly for contact dermatitis. So someone has a really, really, really bad contact dermatitis and it's on their face and the genital region, or just very, very widespread, we can use prednisone to improve it much quicker. And then methylprednisolone, same, or can be used for asthma or like acute exacerbations of asthma. So these are, when you hear histamine, that's when you want to think allergy. So some type of allergy. Our first medication, commonly known as Claritin, but also known as loratadine. Important to know that those are the same thing. Again, that's where soldiers could lose a lot of confidence in you if they know that, but you don't. And so knowing both names of those medications is important. Common dose is just 10 milligrams once a day, and it tends to help with seasonal allergies, or like someone who has allergic asthma, it might help them, especially during certain seasons when allergies tend to flare up. It's important to know that these shouldn't be taken in combination. You may have soldiers who are taking like a daily hydroxyzine for sleep, or take hydroxyzine for anxiety attacks. Now, that doesn't mean that these medications can't be taken together. They definitely can, but I would want to be the one assuming the risk and having that conversation with the soldier rather than you all giving them the advice to take these medications together, because that takes the risk away from you all and puts it on me. But yes, soldiers should not be combining these medications without at least discussing it with me first. And then also important to note that like Benadryl is really not the best medication to be taking as a daily antihistamine. A lot of times we'll have soldiers that take it on a daily basis, and I'll probably get into this a little bit more in some other slides, but it is a drowsy medication, and so if they're taking it every day, that's not ideal. It's better to transition them to something like this. Our other great daily antihistamine is Zyrtec, or also known as cetirizine. Again, 10 milligrams every day. Very simple. Sometimes cetirizine works better for people. Sometimes loratadine works better for people. So if they try one and it's not really working, it's worth trying the other one just to see if it does work better. All of the same uses, all the same precautions as loratadine. Benadryl or diphenhydramine. You don't hear diphenhydramine quite as much. Most people just refer to this one as Benadryl. But if you ever hear Banafin, that is actually the same thing. The max daily dose is 300 milligrams in a day. I have really never given someone or recommended that they take 300 milligrams of Benadryl in one day. Even for, let's say, it's like a very, very acute allergic reaction, they have a rash everywhere. If I think that they need that much Benadryl, I'm probably just going to give them a different medication. This can be used for a couple different things. So, I mean, it can be used for itching. It can be used for sleep off-label. It can be used for allergic reactions. Let's say someone eats something that they're allergic to and they break out in a rash. It can be used to very quickly improve their situation. And if they're still able to swallow a pill, it can prevent them from getting to the point where we need to hit them with an EpiPen. And so very easy. I've had plenty of people who have an allergic reaction, and then we give them 50 milligrams of Benadryl as soon as we can, and then we avoid giving them, we avoid having to hit them with an EpiPen. So a lot of different uses for this. It can also be used in like severe anxiety attacks. Hydroxyzine is a better option, but if you don't have hydroxyzine and you do have Benadryl available, it's totally reasonable to give them that medication. And it's fairly low threat, but if someone takes Benadryl and they do experience drowsiness, they shouldn't be like operating heavy machinery, and really shouldn't, in a field setting, it may require even writing a profile that says like if this person is taking, if they're experiencing drowsiness, they shouldn't be doing certain things. Again, want to touch on if you have a soldier that's taking Benadryl 3 to 4 times a day and they think that that's the best medication for their allergies, they really should be transitioned to something else because there are other medications that are less sedative. Phenidine, or also known more commonly as Allegra, common doses would be 60 twice a day or 180 milligrams once a day. Again, used for allergies. There are a lot of people who absolutely swear by this medication and that Claritin and Zyrtec don't work for them, but this one absolutely does. So you might have those people that they fail Claritin and they fail Zyrtec, and so this is the next step to get their allergies treated. This shouldn't, just like all the others, shouldn't be taken in combination with other antihistamine unless it's discussed with me. This medication, fun fact, is also used for GERD. And so if you have someone who has issues with allergies and they're also having issues with GERD, this is a perfect medication where you can kill two birds with one stone. Touch on is olopatadine, also known as Pataday eye drops. This is specifically an anti-allergy or an allergy medication specifically for those people who have allergic conjunctivitis. So what drives them the most crazy when they get allergies is their itchy eyes. And these people honestly will think that you are a hero if you help them with this. They're going to be so happy because they'll go from being so miserable, and these Pataday drops make such a big difference. They are going to absolutely love you. The biggest thing before you were to give somebody Pataday drops, though, is you want to rule out that they don't have a bacterial infection. And so pink eye or bacterial conjunctivitis, and you can see more of this in the HENT lecture that I've given. You want to make sure you're not misdiagnosing that. And so bacterial infections are going to show up in one eye. They're going to have that like goopy, like crusty discharge. They might have some swelling. They'll have the redness. You want to make sure that this is the perfect picture for allergic conjunctivitis and not bacterial, because in that case, this is not going to help that, and they need to be given antibiotic drops. Some familiarization with muscle relaxers. I cannot tell you how many times I've heard stories of medics throwing around muscle relaxers at aid stations. That is really not acceptable if a provider is not at least consulted. So if one of my soldiers, one of my medics believes that someone really needs a muscle relaxer, say for example, they have an acute back injury, they threw their back out, and they took ibuprofen already today, so we can't give them a Toradol shot. That's a good example of someone who may benefit from a muscle relaxer. But medics should not be just giving out muscle relaxers. That's how we end up with people who are abusing muscle relaxers. And so it needs to at least be discussed with the provider. These should be given as, short course medications. This is not something that someone should be on for a very long time. And so some of those muscle relaxers to be familiar with are cyclobenzaprine and methcarbamol. You may have people who have seen pain management or seen us, and they are prescribed these. Important to know that you can mix these with NSAIDs. So, I mean, if someone's taking a daily methcarbamol and they're still having issues, they can take ibuprofen, they can take naproxen on top of that. These medications may cause sedation. So if you're giving someone, if you're in a field setting, you've phone consulted me because they threw their back out and you think they need cyclobenzaprine because the Toradol shot we gave them isn't working, and we're giving them cyclobenzaprine to take every day during the field, they should be on a profile that says that they're not operating heavy machinery unless if they're experiencing the side effect of drowsiness. So that takes the liability away from us. Let's say we put someone on a medication like this and then they're supposed to drive in a convoy and they, roll a military vehicle. And it comes back that they were just given cyclobenzaprine. That's huge. That could really come back on us. And so you have to be very, very careful with these medications, and you have to really cover yourself if we are giving these medications to say, hey, we warned them about this, we told them that this could happen, that they shouldn't be operating heavy machinery, and I even put them on a profile that says if they're experiencing that, they should not be operating heavy machinery. Next, let's get into some familiarization of antibiotics. Again, I wouldn't expect you to memorize any of these doses, really. These are all things that you can reference. And really, as a medic, you're not prescribing antibiotics. That's when, if you think somebody needs an antibiotic, that's when you're reaching out to me and we're coming up with a further plan. But you should be familiar with some of the names of these medications, just because it could give you a lot of information while you're doing your ample, during your HPI, if someone is taking one of these. And so first one to know, this is the one that you do need to memorize, is ertapenem, because that's the one that's used in trauma settings, and you are not going to have time to look that up if you are in that situation. And so highly recommend pausing the video, saying the dose of ertapenem out loud. If you don't know it, look it up. I'm not going to give it to you because that's too easy and you won't learn that way. So pause the video, either say it out loud if you're confident, or look it up and become confident. Next, we'll talk about ceftriaxone. This one is commonly used for treatments of STIs. And so when we're in a field setting, sometimes people do get STIs. This is actually given as an injection, and then we give them azithromycin or doxycycline with it. That is something that we may commonly see in the field, especially on deployments. This does tend to happen a lot. And so being familiar with that one, understanding how to give the injection of ceftriaxone is definitely important. And then azithromycin as well, but oftentimes we're going to give doxy instead. There's also besfloxacin. So if you're very suspicious that someone has bacterial conjunctivitis, we touched on this a little bit earlier with the pink eye, trying to figure out, the difference between allergic conjunctivitis and bacterial. That's in a completely different lecture, so I won't get into it. But if you are confident that it's bacterial conjunctivitis, you can give something like besfloxacin. There's also erythromycin is a good option for that as well. And then there's nitrofurantoin, more commonly known as macrobid because nitrofurantoin is hard to say. Macrobid is used for UTIs, 100 milligrams, 5 times a day if you're a female, or 7 times a day, not 7 times a day, oh my gosh, 5 days or 7 days if you're female versus male. Urinary tract infections, especially in our females, that's something that we have a very low threshold to treat. Say if we're in the field, if they have the symptoms, then I'm going to treat the symptoms. And so this is something I've given quite a few times while I'm in a field or a deployed setting. This medication, it is important to note that you can't give this if someone has G6PD deficiency. So if you ask someone if they have G6PD deficiency, typically they know. If they're like, what is that? Then they probably don't have it, because we're all tested for it when we join the military. And so just asking someone, hey, have you ever been told you have G6PD deficiency? If they say no, then you should be okay to give this medication. But it's important to at least know and ask. Bactrim is another medication. That's one that I'm going to prescribe. That's the sulfamethoxazole trimethoprim. Again, that's one that I'm not giving to someone in G6PD, but it can be used in field settings. This is going to be only, under supervision of a provider. I'm going to be the one prescribing this, not you all. But knowing that sulfamethoxazole trimethoprim is the same thing as Bactrim is important for you all. A couple more antibiotics to be familiar with. Clindamycin. If you have a soldier that has a dental procedure, they'll often be put on clindamycin. Erythromycin, kind of touched on this with the drops or the ointments that can be used for bacterial conjunctivitis. Metronidazole, this is commonly used for BV or bacterial vaginosis. So some of your female patients, they may be put on this medication. This can be oral or topical, and so figuring out exactly which version of the medication they're using is important. Doxycycline, this is given for a very wide range of things. If someone gets like an infection in the field, like a skin infection, soft tissue infection in the field, I've seen it used pretty commonly for that. It's also commonly used for STIs. There's penicillin, amoxicillin, that's our ear infections if we have someone with an ear infection in the field. Or the amoxicillin and clavolante combination is also known as augmentin. So knowing that augmentin is a combo medication with amoxicillin is important. That, like I said, used mostly for ear infections or like sometimes sinus infections. Mupirocin is a topical antibiotic, so this is one I've definitely seen used a lot in the field. If we're afraid that somebody's getting a bacterial skin infection, we can use a topical mupirocin, and that tends to clear it up pretty quickly. We touched on these antibiotics is not because you all are going to be giving them to soldiers on a regular basis, but knowing what they are. Because let's say someone comes in with 3 days of nausea, vomiting, diarrhea, and while you're getting your ample, you find out that they've been taking a couple of days of doxycycline or taking a couple of days of augmentin. Being familiar with that medication and knowing that it's an antibiotic and can definitely cause those symptoms or those side effects is very important. And there's also some education that you can give soldiers who are taking antibiotics, because you may have someone who comes back to the aid station and they're like, yeah, I started to get nauseous, so I stopped taking this medication. And it's super important that, even if someone has those side effects, that they take a full course of an antibiotic, regardless of whether symptoms are getting better or not, because you don't want them to end up right back where they were or even worse than when they started the antibiotic. So it's super important they take the full course and they don't have leftover antibiotics just sitting around. I can't tell you how many times I've heard soldiers say, oh yeah, I started to feel sick, so I took some doxycycline that I had left over. And it's like, okay, there's a lot of issues with that, because that means, one, you didn't finish the full course the first time you were prescribed the doxycycline, and now you're taking it inappropriately, not as prescribed. And it's probably, usually when I hear that story, it's not something that's indicated at the time. So a lot of things that make my eye twitch when I hear that, and I hear it quite often. So, those are the things that you all can hopefully educate people on at an aid station level to prevent that from getting to me. And of course, these medications can cause some stomach upset. So you can tell your soldiers if they are experiencing the nausea, vomiting, diarrhea with these medications, just telling them to take a probiotic supplement. You can buy those at the store. You can order them on Amazon. Or increasing their probiotics in their diet. So like milk, cheese, yogurts, cottage cheese especially, those kefir drinks, stuff like that. They're very easy to find at a store, very easy to order online. Anything that has increased probiotics in it. Some antifungals. Some common ones are tinactin. We're going to give that for athlete's foot. Important with all of these fungal infections to educate your soldier on proper hygiene techniques and how to prevent these things. Obviously, good hygiene in the field is difficult, but there are ways to do it. And so changing socks frequently, changing out of sweaty, damp clothes as quickly as possible, doing the baby wipe showers, doing what you can to prevent these things. There's also clotrimazole. I'm usually going to give that if the tinactin doesn't work. I'll usually start with the tinactin, but either one, perfectly good options. And then ketoconazole shampoo. So this can be used for tinea capitis or tinea versicolor. If you're not familiar with tinea versicolor, reference the dermatology lecture that is also recorded. With the topical shampoo, with the ketoconazole shampoo, you do want to make sure they understand that they need to lather in the shower, let it sit for 5 minutes, and then rinse it. And they have to do that at least twice a week for this to make a difference. The first one that we'll talk about is loperamide. This is really the only available medication that we have for diarrhea specifically. Also known as Imodium, someone could just buy this at the store themselves. It's important to understand the dose of this one. So first they're going to take 2 pills because each of those pills are 2 milligrams. And so the initial dose is 4 milligrams. They're going to take 2 immediately. And then after every episode of diarrhea, they're going to take 1 pill or 2 milligrams. And so they don't want to take more than 8 pills in one day. And so that's 16 milligrams. If we're prescribing this from the aid station, really, like, we're not going to give someone more than 8 because I want to make sure that they don't take more than 8 pills that day. The common use, this is only used for diarrhea. You want to make sure you rule out some red flags. So you're using ADTMC, of course, as usual. And if there's blood in the stool, we're not giving a medication like this. That needs to be further worked up in a different way. You've also, if you've worked with me for a while, you've probably heard my spiel as far as like nausea, vomiting, and diarrhea. To some degree, like, there's something in that person's system that their body is trying to get rid of, right? And so these medications are going to make them feel better in the meantime, but really they have to get it out of their system. So if they're nauseous and vomiting and they have diarrhea, I'm going to ask them which of those symptoms is bothering them more. Most people are going to choose the nausea and vomiting from my experience. And so I don't give loperamide very often, but let's say someone only has diarrhea and they have something very important that they have today that they just need to get through. This is a medication that can kind of help them get through the day. But like I said, it's not fixing the problem. It's making them feel better. Nausea, vomiting, diarrhea together is a pain. There's certain levels to it as far as like, does this look like somebody who needs to go home on quarters? They should really look like they are sick if we're sending them home on quarters. There's things that you can do to identify whether or not someone is really truthful about how nauseous, how much they're vomiting. If they're sitting there very comfortably talking to you, they're probably not experiencing nausea, vomiting, diarrhea. If they look sick, like they're asking you for a puke bag because they feel like they're going to throw up, or they're running to the bathroom in the 30 or so minutes that they're in the aid station, that's someone who might need to go home. But otherwise, it's someone who can be on a profile that says, hey, they have to stay within a certain distance of a bathroom, have to have access to a bathroom throughout the day. That way we can avoid sending people home when they really don't need to be sent home. Diarrhea medication, and the rest of our medications for the most part are to treat constipation. And so our first medication is bisacodyl, also known as Dulcolax. In ADTMC, it recommends giving bisacodyl for a little while and then transitioning someone to Miralax because this one works a little bit quicker and that one's a little bit better to take long term. And so common doses would be like 5 milligrams twice a day. And you don't really want to use this for more than 1 week. If somebody feels that they need to use this for more than once a week, that's when they should probably come talk to me and we can come up with some better options. Always, of course, using ADTMC to rule out any of the red flags. And it's important that you at the aid station level educate people on how to prevent this from happening. So we have a lot of soldiers who don't eat very well and don't get enough fiber and don't drink enough water, and they end up with chronic constipation. And what they think is normal isn't necessarily normal. And so someone should be using the bathroom once or twice a day, at minimum every other day. If it's any less than that, like that's a problem. And they need to make some dietary changes to fix that in the long run. And so telling them to adequately hydrate, to increase fiber. Nobody gets enough fiber in their diet, and there's plenty of supplements that someone can take to increase fiber in their diet, but also just increasing the foods that have fiber in it is a much better option because they're likely going to be replacing those foods, replacing really not healthy options with options that are high in fiber. And then exercising. So when someone's very constipated and their stomach feels horrible and they have the cramps and they don't feel great, really like getting up and moving is one of the last things that they want to do, but it's exactly what will help them. So like staying stagnant is only going to make constipation worse, and movement is what's going to help them. And so they need to get up, they need to go for at least a long walk, go for a little bit of a jog, do some lifting, do some ab exercises. Those things are going to help get things moving. Miralax, also known as polyethylene glycol, but nobody ever really calls it that. So just Miralax. This one is great because you're kind of killing two birds with one stone. Like, yes, this is an osmotic laxative, so it's going to get things moving. But because you mix it up in water, it's also forcing them to drink more water. And so that's what's great about this one. If they need to use this for more than 2 weeks, they probably should come talk to me and we'll have to figure out some other options. And of course, again, you're asking them all of the red flags on ADTMC, making sure that none of those are present. Next, we'll talk about cholase, doxystate sodium. This is just another option if the other two don't work. This one is a stool softener rather than, say, like Miralax is an osmotic laxative, which means that it brings more water into the colon. This one actually just softens stool. And so another option to use if the other ones don't work well for somebody, but ultimately if they're trying all these medications and failing, that's when we need to talk to them about the patient education that we kind of touched on the last slide. So next, that covers our constipation medications. Going to touch on GERD or heartburn for a little while. A lot of times, people who have heartburn know that they have heartburn. So like know that they have a history of it. They tend to know what flares it up. Omeprazole is an over-the-counter medication. And so this is where I allow my medics to stray from ADTMC a little bit because the ADTMC algorithm for heartburn is not very well updated. And they're still using a medication called ranitidine, and that medication is no longer recommended. And so omeprazole is a much, much, much better option. This is something that anyone could buy for themselves over the counter at the store. And it's very easy to give someone 10 milligrams daily with a meal. You want to make sure they understand that they should be taking it on an empty stomach about 10 minutes, or not about 10 minutes, my bad, about 30 minutes before a meal. Okay, so they're taking it before the meal on an empty stomach and then they're eating. Depending on when these symptoms tend to bother them more is when they can adjust when they're taking it. So let's say when they lay down to go to bed at night, that's when these symptoms tend to bother them. And so we can recommend that they take the medication before dinner versus like if it tends to bother them at PT in the morning or like at work when they're sitting at their desk, they can take it with breakfast. It just depends on when it's bothering them more. And so this is the biggest thing here is it should be someone who's familiar with this, knows that they have heartburn, and we've ruled out that this is not cardiac related chest pain. And so if there's some reason to suspect that someone has like cardiac chest pain, we're not going to throw omeprazole at that. But this is like classic picture of heartburn where it's just kind of that burning type feeling in their chest. It's right after they eat spicy or acidic food. It's when they lay down flat. Those are all the things that point us towards heartburn rather than cardiac chest pain. Oftentimes in our young healthy soldiers that we're seeing, it's this and it's not cardiac chest pain. It's very rarely seeing cardiac chest pain in my young soldiers. Also, there's a lot of basic precautions or like lifestyle modifications that you can discuss with people to really improve these symptoms. The good thing for us is that we have very easy access to a nutritionist or a registered dietitian over H2F. And so you can tell them to go talk to these people because that's something that she specializes in is dietary changes to improve stuff like heartburn. And so the basic lifestyle changes that you can tell them at your level is avoiding the triggers. So avoiding spicy food, acidic juices, reducing alcohol, coffee tends to do it. Other simple things like sitting up for 1 to 3 hours after eating. 3 hours is ideal, but they should be sitting up for at least 1 hour after eating. Someone who eats dinner and then goes straight to bed, they're going to experience these symptoms. And if you just think about, the anatomy and why that would be is the stomach, the acid is kind of refluxing back up through the esophagus. And that's much easier when someone is laying flat. And so if they're someone who likes to, hang out and watch TV after they eat, they should at least be propped up. Or they can put something under the headboard pegs of their bed so that their bed is a little bit elevated in that way. Couple little modifications that they can make there. And then they can use Tums as needed for episodes, even if they are taking omeprazole. So if they're taking omeprazole and it works most of the time, but then they eat something that they know they shouldn't, and they just have a little bit of an episode that flares up, they can still use Tums with that. So next, let's talk about ondansetron or Zofran. Very important to understand that this is not an over-the-counter medication. And so this is not one of those ones that we can just send people to La Pointe to pick this up. This is a prescription medication. It needs provider approval. However, if we have this available at the aid station, all it would require is a phone call to me, briefing me on this patient and saying, hey, I think they'd benefit from Zofran. They have the nausea, vomiting, diarrhea. I asked them which one is bothering them more. They said nausea, and they're actively like, they look sick. They're asking me for a puke bag. I feel like they're gonna throw up in the aid station. Like they look bad. They might need to go home, depending on if they do look that bad. Or we give them this option if there's someone who doesn't really look sick. It's like, okay, well, let's give you this and see how you do today. Make sure if it is the oral disintegrating tablet that they understand that they do not just swallow it. So you have to let it dissolve on your tongue. If you swallow it, you're just going to throw it up and then it's not going to work. Simple cold and flu medications. First one is Cepacol. This is just a lozenge somebody could pick up at La Pointe Pharmacy by themselves. They don't even need any sort of a prescription. It's just benzocaine lozenges, so it kind of has that numbing effect and makes your throat feel better, helps with coughing, works really well for someone who just has that lingering sore throat, a little bit of a cough, nothing crazy. Doesn't necessarily need to go home, just need to make it through the day. Easy to just send this person to La Pointe to pick these up. On Afrin, this is a nasal spray, also known as oxymetazoline, but no one ever usually says that. Everybody knows this is Afrin. Common dose would be like 2 sprays twice a day. It's used for nasal congestion and can also be used in the setting of epistaxis, so our acute nosebleeds, and you're using it when the nosebleed is happening. This isn't something that you're using to prevent nosebleeds, but if someone has a nosebleed and we're having a hard time getting it to stop, this is a good option for that. One thing that you do want to make sure you tell your soldier is not to use this for more than 3 days. So they can only use this for 3 days. And then if they don't do that and they continue to use it for longer, it could rebound back worse. This is decongestant, and so there's slightly increased risk of dehydration. You want to make sure you tell them to increase their water intake. Medications where you'll see Sudafed and Mucinex kind of combined, but guaifenesin is more associated with Mucinex. That is what I'm giving people who have the chest congestion. So there's the kind of like the sinus congestion versus the chest congestion. Mucinex is for the chest congestion. And again, like these are over the counter. This is something that they can pick up themselves. Next is pseudoephedrine, also known as Sudafed. Like I said, there are combination medications that this can be in combination with Mucinex. Usually they're easier to pick up themselves. They can buy it at the store. They can pick it up at La Pointe Pharmacy. Sometimes Sudafed does cause like a jittery kind of feeling for some people. And so there's some people who, if we recommend Sudafed, they're like, no, that medication makes me feel horrible. That's not totally abnormal. I do hear that quite often. Again, if this is a decongestant, so you're telling them to increase their hydration. If someone is taking this and then going out and doing some crazy stuff in the field, they would be at a little bit higher risk of dehydration. Antibiotics, so we kind of touched on this. I think these are just replay slides. Let me go through those. And then we just have some miscellaneous medications. So albendazole, this is a fun one if we ever get to give this one. I've only given this medication twice. It is used for pinworms and intestinal parasites. The story here, anytime that I have given it, is like I used the bathroom and I actually saw a worm moving in my stool, or like I know that I have pinworms. I've had them before, I got them as a kid, and now we're in the field and I have them right now. Not a fun one to deal with, but these are people that definitely need our help, right? So albendazole, one to be familiar with. If any of you all are giving albendazole, that's one that I should be familiar with, one I should be getting a phone call about if I'm not there. Another medication is phenazopyridine or azo. You can typically buy this over the counter at the store. This is for like UTIs. The biggest thing is we shouldn't just be giving this medication alone. If someone has the symptoms of a UTI, we need to make sure we're actually treating the UTI, but this can make them feel a little bit better in the meantime. But you want to warn them that it will turn their urine like bright orange or red. because people will think that something terrible is happening if they use the bathroom and it looks like tie-dye in the toilet bowl. Make sure they are aware that this medication will do that to them. Another medication is chewable calcium or vitamin D. This very easy to use at the aid station for soldiers that have concerns for any sort of like a stress injury. A lot of our soldiers do not have enough vitamin D in their diet. It's something that I pull the lab for all the time. It can cause stress fractures. It can cause the feeling of like fatigue or depression. A lot of times low vitamin D. We don't get enough of it in our diet. And especially during the winter months when the sun isn't out as much, we're not getting exposed to it through the sun. And so chewable vitamin D and calcium, they're pretty harmless. The calcium, the only risk is if you take too much of a calcium supplement, it could cause kidney stones. And so it's better to give a vitamin D supplement and just make sure that you have enough calcium in your diet. And so that's another thing you just recommend, increasing things that have calcium and vitamin D in diet. Another miscellaneous medication you should be aware of is nitroglycerin. A lot of times we do have these at Role 1s, and I have never used it in a Role 1 setting. And that's because I should be the only one giving this medication. We need an EKG before I'm comfortable giving this medication. And so in a Role 1 setting, I'm very, very infrequently giving this medication because there are some things that we need to rule out on an EKG. So something to be aware of, if you have someone with chest pain and you're handing off to EMS, for example, making sure that you get a good ample is important, because let's say that person has taken sildenafil or Viagra within the past 24 hours, they cannot be given this medication. And so that's something that you could really make a big difference by getting a good ample and making sure that the EMS personnel know that this person has taken sildenafil within the past 24 hours. Then they know that they can't give nitroglycerin. Another medication, now I don't say that you need to memorize a lot of medications, but this is one that you absolutely do need to memorize. Epinephrine or the EpiPens. If it's not an auto-injector, you need to know how much of the medication you're giving. So for an anaphylactic reaction, this is someone is exposed to something, their throat is closing up, they're having trouble breathing, those kinds of things, having trouble talking. 0.3 milligrams IM is what you're going to give that person. Now, if somebody has an allergic reaction and they're breaking out in hives and they're kind of like nervous, I've seen this happen before, and people think that they need to jump straight to an EpiPen just because they're exposed to something they're allergic to, even though they're sitting up, they're talking to you, you're having a whole conversation, they don't seem to be struggling. That's somebody you can hit with Benadryl, right? Like some EMTs and some young medics get real excited about getting to hit someone with an EpiPen, but that's not always the answer. So make sure you understand what a true anaphylactic reaction looks like. If that person's wheezing, if they feel like their throat is swelling up, if their lips are swelling up, that's someone that we should be hitting with an auto-injector. If they're sitting up talking to you, but they break out in hives, that's somebody we treat with Benadryl. And then last medication we'll talk about is valcyclovir. This is used to treat various viral infections. There are topical versions of this and there are oral versions of this. It's just one of those, be familiar with the medication and know what it treats. A lot of people take it for HSV, so like herpes simplex virus, either for prophylaxis or when flare-ups occur. It is not one that reacts with many of the medications that we're giving, but just knowing what it is and what it does is important. And that is all of our medications that we're going to discuss today. If you have any questions, feel free to reach out to me. Hopefully this just gave you a good overview of medications. Like I've said multiple times already, it's just being familiar, knowing what medications fall into what classes, and there's certain medications that you need to know the dosages of. If you have any questions, feel free to reach out.